Hello, everybody. This is Connie Van Egan at the University of Vermont, welcoming you to today's NNECTR Spring Seminar session. We have a great group here today, and I'm going to go ahead and get us started. There's a process of just coming in and listening, but I ask people to mute themselves as they do come in, especially during the presentations. There will be question and answers at the end of this discussion. But please feel free to post your questions during the presentation into the chat, and we'll use those to help get the conversation started at the end of the presentation. I'm going to go ahead and start introductions, and I am grateful to be able to introduce two distinguished investigators. Julie Fritz is a distinguished professor in the Department of Physical Therapy and Athletic Training. I will slow down. I'm a New Jersey person and I talk faster than my mouth goes. And the Associate Dean for Research in the College of Health at the University of Utah in Salt Lake City. Her research has focused on examining non-pharmacological treatments for persons with spinal pain, including clinical trials and health services research. Currently, Dr. Fritz leads projects funded by PCORI and the National Institutes of Health, including projects funded under the HEAL initiative addressing pain management and opioid use. She also leads studies with the NIH, VA, and Department of Defense Pain Management Collaboratory, investigating non-pharmacological pain management in the military health system. Sebastian Tong is a practicing family physician and addiction medicine specialist. He is an assistant professor of family medicine at the University of Washington in Seattle, where he also serves as the associate director of the Washington, Wyoming, Alaska, Montana, and Idaho region Practice and Research Network. I think it is fondly known as WWAMI. Yes, what a great name. He conducts research in practice-based research, substance use, loneliness, and chronic pain, and has received funding from the National Institute on Drug Abuse, the National Institute of Nursing Research, and the Agency for Healthcare Research and Quality. Thank you so much, both of you, for being here. And I will turn the talking stick over to Sebastian to lead us off.
Great. Thank you so much, Connie, for the really fantastic welcome. Uh, I think I can speak for Julie and myself that we're both delighted to be here and to share a bit about our work with Care for Health and what we're doing with this new initiative about I guess at this point, 8 months, 6 to 8 months in at this point. So it's been really a whirlwind. I'm just going to go ahead and share my slides. Okay, there we go. Um, So I'm going to talk a bit about our specific hub, the Care for Health initiative, and then have Julie talk about BeatPain and how we've integrated into BeatPain. Um, so we'll start with a broad overview of Care for Health, specifically about our network out in the WWAMI region, as we call it in Oregon. And then Julie will talk about the next two items. Our disclosures are that we have funding from NIH to do this work through both the Office of the Director and NINR. Both Julie and I have no other disclosures. So the initial slides, I think, are things we're all familiar with. These were the slides that Dr. Bertagnoli used, who was a previous NIH director, to introduce the Care for Health initiative and really talk about why it was important to do this initiative. And interestingly, I think an interesting thing for us to note is like the importance of having the right conversations at the right time. I think she was on, like, she already had a huge interest in disseminating out into the field into rural areas. She is originally from central Wyoming in a very rural area and has written and talked about that extensively. And I think she was on a site visit to the University of Alabama, and the Department of Family Medicine chair had a few minutes with her individually, just between sessions, and talked about just like this idea of starting this network. And hopefully, I think that's like what stemmed this, but I think he had an interest in it. So it was like really pushing the needle on like getting something like this started when someone already had that interest. So it really highlights the need to be prepared to talk about, I think, our work and how important it is at any given time, I think. So she brings up how really we're like pretty close to last out of 10 other developing countries in many situations and many kind of rankings and metrics, despite spending the most money. And then we see that not everyone is adequately represented in research. And one of the things that she drew out was really people in rural locations, especially outside of academic medical centers, do not receive opportunities to participate in clinical research. And like often people with comorbid conditions are excluded, people who have other complications to their medical care, and often people who are uninsured or older are excluded as well. So she proposed this initiative called Care for Health, initially Communities Advancing Research Equity for Health, um, to really bring research to rural communities. And then I think one of the initial corrections from the very beginning was it's really not doing things to rural communities, it's doing them with and for and kind of in collaboration with rural communities and making sure it's bidirectional in nature. So one of the initial program objectives was to just develop an infrastructure for a primary care focused clinical research network, which I think sound very familiar to us in the PBRN world because we do that work in practice-based research networks, and establish a foundation for sustained engagement with the community. It was really great to hear from the beginning that they really wanted something sustained, and looking at innovative study designs. How do we do research in routine primary care, and how do we make sure we adopt the evidence-based research findings into practice? So this started currently, it's in year one of a 2-year pilot. Um, the initial call was for network research hubs, and the NIH is providing kind of an operations center and a clinical science center to do that work. And we're forming committees to kind of advance some of the work that's going on. This just provides a bit more detail. There's a lot of words on the slide. I think this was their initial introduction slide of the overview. And I think what's really exciting is to hear the words whole person health and looking at spanning treatment and prevention and sustained engagement with communities really coming out of the NIH. So these were the initially funded hubs. The University of Washington is part of Oregon and Health and Sciences University's hub. So ours was the green space that takes up a lot of the kind of top left of the map. We were initially funded along with University of Wisconsin and West Virginia University. And then we were funded back in September, and in January, Oklahoma, New Mexico, and Alabama were added to the network hubs. And I think from what I've heard is is a future plan to increase and involve more hubs as well, but that we'll see what happens with the NIH funding and if this remains a priority of the current director. So the plans for this network research hub, it's initially funding these hubs. Initial hubs were engaged in enrolling for a current NIH funded study. Or we're partnering with Julie study, which we'll talk about a bit later. And the next step is really looking at developing this like clinical science center and operations center. And one of the things we're being asked to do right now is co-design innovative studies with practices and communities and propose them for funding at the NIH level that is outside of the traditional no for RFA mechanism. And then I think all of us in the primary care community are helping to expand and like envision what this looks like beyond 2026 and to participate in shaping what the network looks like. So why did we decide to be part of Care for Health? When it came out, as you probably know, there was about a 2-month turnaround to submit a pretty complicated application, and we were like, should we be doing this or not? And I think Allison Cole, who's a WPRN, our network director, and I did some brainstorming and reached out to Melinda, who's the Oregon Rural Practice Research Network director, and we decided to go in together to help each other, support each other in this application process. And I think we really wanted to find some infrastructure to build. How do we build and work on underrepresentation in clinical research? How do we extend research participation in places that don't usually do research? And I think really, instead of often, I think because of lack of infrastructure, we're often reactive to studies that are funded or reactive to someone who's saying, I have a proposal due in 2 weeks. Can you write me a letter of support? So we don't have a chance to shape studies. But really taking a step back and doing listening sessions and hearing what the community wants, and then moving forward to propose that. I think those were really big opportunities that we wanted to be in at the ground level to help shape. So as I mentioned, the WWAMI Region Practice and Research Network. So Connie said the Washington, Wyoming, Alaska, Montana, Idaho, and then the Oregon Rural Practice Research Network joined forces along with support from our institutional CTSAs to really bring forth this center together that we're calling PRaCTICE, or the Primary Care Rural and Frontier Clinical Trials Innovation Center. So a lot of acronyms. To bring forth into this new hub. And both of our PBRNs bring a long history of research extending about 2 decades each, and have really engaged with a variety of practices across those member states. Oregon focused entirely rural. Ours is a combination of urban and rural, and and both states have a large percentage of people who are Hispanic workers. Ours is more Asian. They have more American Indian, and some focus on peoples with disabilities as well. And both have a governing body that's either an advisory board or a steering committee of primary care clinicians and clinical partners from the rural areas as well. So this is a map that shows forth what we proposed initially. The sites that are starred in yellow are initial partner sites that we're focusing on in the first 2 years of our practice network. And then Orprin's sites that are existing are in the blue in Oregon, and our ongoing other sites that work with us closely are in red. So you can see we have sites to like pretty well distributed across Washington, Oregon, some in Idaho, and fewer in the Montana, Wyoming, Alaska region. Although for the Alaska region, that's not the scale, but like very few people also live in those regions as well. So the map may not be representative of how the population's in the area. So these are initial sites that worked with us. They have substantial percentages of rural populations, many who are FQHCs, rural health clinics, and some who are just health system clinics in rural areas. We shaped our practice network and proposed it around 4 different cores. The community engagement core is doing the work that's like, as I mentioned, the listening sessions, and I'll talk more about the community engagement work that we're doing. The recruitment and trials core is doing what NIH is proposing as the initial work to engage with specific NIH-funded studies that are ongoing. And then we thought it was important to have a data coordination core. One of the big things coming out of the NIH is how do we harmonize data? How do we work with data across different data systems? How do we look at EHR data together? So we thought it was important to have that. And then also make sure we had a communications and dissemination core that's focusing on presentations and focusing on what type of manuscripts and beyond presentations of manuscripts in traditional academic forms, how are we doing that out in the community as well? So to dive a bit more deeply into our communication strategy, community engagement strategy, um, we took a kind of six-pronged model approach. Um, Number one is building on a regional engagement specialist model. So we didn't have that in the WAMI region where we had people out in the region, but Orpin has this model where they actually have research coordinators who they call research regional engagement specialists spread throughout Oregon and living in communities so that they're able to more easily access different communities and attend community events or just know people in the community. So we're trying to replicate some of that into the WAMI region, initially by doing more frequent visits, but I think hopefully in the future also expanding to actually having people located in smaller communities who can know the communities better and better engage people. Number two was a community needs assessment, and I think I have another slide about that. Let me just, yeah. So the community engagement needs assessment is looking at the existing community needs assessments that are required. I think by statutory Medicare or that each health system in county is required to do. So we took a look at that and really reviewed that instead of really redoing our own, because I think doing a community needs assessment in every single area in the six-state region would be prohibitive. So we're starting with the Washington, Wyoming, and Oregon ones and looking at when they were published, what priorities they have, what demographics, and kind of collating that data together to summarize that information. We are doing a whole bunch of regional listening sessions across our states. So some in Colville was in northeast Washington in a very rural area. We went out to Casper, Wyoming just last week to do two listening sessions out in Casper. In a few weeks, we're going out to the Yakima region and conducting some listening sessions in Spanish with some migrant farm workers out there, and then also doing work across Oregon as well. And then what's missing here is we're also going out to Idaho later in May as well to do individual listening sessions. And those sessions are really focused on the broad questions of to family physicians, what are some of the priorities that you hope research will focus on, and what are some of the barriers and facilitators to participating in research? And if we're talking to some people who don't even know what type of research PBRNs do, so really also it's informative to them as well. It's bi-directional, even though it's a listening session for them, to share with about some of the things we do as a PBRN. And then the next few steps we did were co-designing studies. We're having drawing together an annual meeting where we're drawing together different participants. And then the last step that we're just finishing up right now is our new study development process. So Care for Health is designed as like year-long process where we're taking critical clinical questions from communities and using those to identify clinical study concepts that then Care for Health work groups that are made up of the different hubs will prioritize for study development. And then the core team at the Office of Director is going to take those back to the different NIH institutes to see if they're interested in co-funding them based on what emerged from the hubs and the clinics that we're working with. So one of the things transitioning beyond community engagement to selecting year one studies is that one of the core components of this was making sure that the hubs could recruit for trials and really be participants in research and learn from those experiences as well. So back in August, when we were in negotiation for funding, the NIH provided a list of 10 studies for us to rank for year one. We decided to rank them as like go, maybe, or no, like whether this would be possible for us to do. I think some of the studies involved intensive blood draws, and we said that's just not possible in the context of clinical resources in these very rural communities. And we reviewed each study and ranked them based on kind of past research experience, clinical site capacity, and also like what we thought would be of interest to clinics as well. So after submitting to that list, the NIH facilitated two meetings per study with PRaCTICE and the study team. It was kind of what I called speed dating, I think, for facilitated by a parent, because the NIH was like, we weren't funded yet at that point, right? So like I felt like we were having like a speed dating that was supervised by a potential funder at that point, which was a very interesting experience. And we would then told like we were each individually asked afterwards like, do you think this is a good fit? I think, and then we were matched with we were matched with two studies. Some sites were matched with one, depending on interest, and those that matched with two were giving more resources to do those. So I'll talk about briefly about the other one that isn't Julie's trial, and then I'll let Julie introduce BeatPain. So one of the co-care study, which is not Julie's study that we matched with, is a National Institute on Drug Abuse (CTN) clinical trials network study. And that one is looking at collaborative care for polysubstance use. And it is a very, if you know anything about CTN studies, it's a very protocolized, very study that like there's a lot of check boxes and check marks to do. So we're working through that with a Eastern Oregon site. And we're trying to recruit 50 patients into that have polysubstance use disorder, and half of them are getting nurse care management and contingency management for 6 months. And then I will let Julie talk a bit about this one. I can advance your slides for you if you want.
Yeah, that'd be great. Thanks, Sebastian. So I saw a comment in the comments about what an interesting process this sort of matchmaking was. And you know, I think both Sebastian and I would say it definitely was. So to kind of give you the context from the other side of this matchmaking, at the time this was going on, I was leading this trial that's still ongoing. And the our program officer reached out and told us about this opportunity to be a site that could match with one of the Care for Health teams, and that basically we would just bring them into our study, and so that these sites could participate in ongoing research. And so I too got to do a little speed dating with a couple different groups and talked about what our study was and talked about potential fits. So it has been a really interesting process. So I just want to take a few minutes to orient you to the study that was ongoing and is now has practice sites participating. So this particular study is funded under the HEAL initiative. So it's focused on pain management and substance use, opioid use. And we are partnering with federally qualified health centers, starting with our FQHCs who are here in the state of Utah. This is a very pragmatic trial. It's part of a group called the NIH Pragmatic Trials Collaboratory. And really is a partnership of a number of different groups here at the University of Utah. Go ahead to the next slide, Sebastian. So just to kind of set the clinical context, I'm sure I don't have to convince any of you that chronic pain is a large and consequential issue in the U.S., especially in underserved communities. You can see some of the statistics here. And in particular, our focus is on high impact chronic pain that impacts people's daily activities. And the fact that this is overrepresented in rural, lower income or communities, households with lower educational attainment, the communities that are served by community health centers. Go ahead, next slide. So this is our, just to give you the setting in Utah. In the state of Utah, we have 14 community health centers scattered throughout the state. Utah is a very big state with very concentrated areas of population and a lot of very rural, remote places. So you can see that on the map here. And just some data. This is pretty consistent with community health centers and the population they serve. High percentage of individuals who are part of minoritized racial or ethnic groups. In Utah, there's a lot of that diversity is Hispanic Latino individuals, many of whom communicate best in Spanish and do best receiving their health care. And also you can see the statistics in terms of the household income levels. And again, this is typical of CHCs. Go ahead to the next slide. So our goal in partnering with these community health centers, which we've done for a number of different projects, but we had a shared goal around improving pain management, reducing the primary care tendency to have to rely on medication management because of the lack of non-pharmacologic options in communities that are medically underserved. So this is, as I mentioned, a pragmatic randomized trial. Our primary question is one of effectiveness, but we're also studying how to implement the interventions that we're doing. And basically what we're studying is telehealth provided by physical therapists to address pain management in these communities. Go ahead, next slide. So this is the study related details. Probably the most important thing to say is that this trial is decentralized. It's all remote so that we can partner with these clinics all over in very geographically diverse places. We're studying a brief versus a more extended delivery of the treatment. You can see we have an adaptive intervention arm. And importantly, we're exploring the implementation outcomes for just implementing all of this in hopefully a manner that can be sustainable. Go ahead to the next slide. I won't go into detail here, but this is a pragmatic study. We're trying to be very inclusive. Probably important things to note here is the accommodation to the Spanish-speaking population. That was obviously critical for partnering with these clinics. Yeah, otherwise we really were trying to be very inclusive of people with chronic pain. Next slide. And this is the decentralized nature of the trial. So as we began working with Sebastian's team and the PRaCTICE network, this was really where a lot of focus was initially, is how do we take this process that we've set up and implement it on the fly in new clinics. So what we really, a key component of our research team is biomedical informatics expertise to work with the EHRs that are in community health centers so that an individual provider seeing a patient can send us an electronic referral through the EHR that comes to our team, and then we can outreach to the individual to invite them to participate in the study. We've supplemented that, just before you go on to that, we've supplemented that with also a text messaging campaign so that hopefully we can make sure that we at least reach out to patients who might not have been offered that opportunity during the clinical encounter and send them a text message which can come back to the clinic so they can send us a referral if the patient requests it. Go ahead, Sebastian. And you can just click through there. Sorry, I didn't realize I had, yeah. So this is just to tell you where we're at. We've now engaged with 10 FQHC organizations altogether in 3 states, which is the addition of Sebastian's team. You can see some of the data there on how many different clinics, how many different providers have sent us referrals. Overall, we've had over 1,000 people referred to us. And probably there, the most important thing is just some of the demographics of the participants that we're working with in terms of, and this is what we expected in terms of representation of Hispanic, Latino, and Spanish-speaking participants, as well as rural residents, and you can see the insurance status. So we're capturing the population that's receiving care in the community health centers in I think, a fairly representative way. Go ahead to the next slide. You want to take this one, Sebastian?
Sure. So our 2 sites that we're doing, one is on the border, right on the river between rural Oregon and Washington State, that has we'll call One Community Health, or OCH, and the other one is in Casper, Wyoming. It's a University of Wyoming affiliated SQHC, and so part of what we've been doing is doing site study startup, getting IRBs approved, getting data transfer agreements, and kind of providers oriented. Julie will talk more about how we've been doing recruitment. So as is kind of, I think, as expected with different sites are progressing at different rates. The One Community Health site has been able to get through all the regulatory work. They had some problems with getting, I think, the referral set up initially, but now have overcome that barrier and are letting providers actively recruit patients. We have research coordinators out there doing tabling to help with recruiting more patients. And meanwhile, what University of Wyoming, we've had a lot of back and forth and trying to get the right people in the room about, like, Is it a IRB reliance agreement? Is it a data use agreement? Is it a business agreement, associates agreements? So I think we're still working out those details and hoping to launch shortly. I think one of the added barriers there is that they have, since it's a FQHC that's tangentially kind of affiliated and relying on an IRB that is academic in their state. I think the communication there is harder to kind of all coordinate together. So we're learning a lot about just EHR operability for sending it and receiving referrals. I think we're learning a lot about just interpreting research regulatory requirements and kind of the needed time to have all these things reviewed. Oh,
Yeah, and I would just add to that, from our perspective, I think the regulatory requirements has been a real challenge. The work we're doing is so very pragmatic that difference, and this was occurring within Utah, and then we branched out. How to think about the IRB oversight, working with community health centers. It's a very pragmatic study. Who exactly is engaged in research? This has been interpreted differently by different people, and that's been one of our, I think, really key challenges. Otherwise, I think it's been interesting to talk to my team as we have more patients coming in who are now outside of the usual cohort that we've been working with. There's an awful lot of similarities because these are all community FQHCs. But some interesting, unique differences. And we've had to think about things like our branding as being in the state of Utah, and that's come up a few times. So, some different things that as we've brought in people from outside of the groups that we were working with, the way we communicate about the study, the way we describe what we're doing, the way we introduce ourselves, like, as part of the University of Utah, that's been an interesting journey for us to learn how to make sure that our language and communication is not presenting any barriers or any confusion on the part of patients about why somebody from the University of Utah is reaching out to them in rural Oregon or something like that. So, I think at that, Sebastian, I think we're ready for some questions.
That was such a great overview and such a deep look at what some of the challenges could be when we're trying to do something like broaden the base of who is involved in clinical research. So, what an overview and what insight. Thank you. I have a couple of questions. I'm keeping my eye on the chat, and there's been some thumbs up on wanting to see slides and also the whole experience as Sebastian was talking about it of what this must be like. I have just starting off a really basic question that comes to my mind because it sounds like there's two things happening in the world of clinical research at the same time. One is how do we better engage underrepresented folks, which is we have a study. Would you like to come in? Kind of the speed dating piece. And on the other hand, it's what are the important things to study that underrepresented folks are burdened by? Let's just use that word. And so when, so it sounds like there's a developing process which starts with, well, here we have BeatPain. Let's start engaging folks in BeatPain. But the expectation is that the flow will get reversed in some way, and that communities that you've been working with turn around and say, well, here are some of our priorities. Here's what we care about. So can you do research on this? And I wonder if you've thought about that or had insight on how that might happen.
I can speak to our experience with this particular project. I have colleagues who actually are based in our cancer center who formed a lot of partnerships around different screenings and such related to cancer with these community health centers. And they have an advisory board with patients and providers. This is what probably now 5 or 6 years ago, those folks bringing an interest and expressing a need for pain management options. And that investigator who at our institution through the cancer center came to me to say there's interest here. So it really was a topic of interest that came from our community health center partners, or else this project wouldn't exist. So, and we continue to engage with those both patient and clinic and staff partners as we try to expand our own work to make sure that what we're offering has value to our community health center partners. And it sounds like, Sebastian is very much conducting a similar process of understanding what the needs are.
Yeah, I can say like our network started with a bit of that. Like one of the things I didn't talk about in the WAMI Region Practice and Research Network is that like we try to really do studies that meet our clinicians' needs from the very get-go. So like we have a steering committee of clinicians from all the outlying areas, and every study that we do, we have them approve and give feedback on it. We say no to some studies when we have academic researchers approach us that just don't meet those needs. I think this is a really big chance to completely turn that around and hear from a clinician perspective, where do we even start? What are the studies that are of interest from like the beginning? I will say one of the things that we're hearing maybe isn't what NIH can do sometimes. It's very much the process questions, right? Like it's how do we make things better within the system. Unfortunately, the questions that are emerging are really not disease specific and focused, and so it's really hard to put those into specific NIH institutes. So it's going to be a journey to see what happens in the next year.
Thanks, Sebastian. I see Gary's hand up. Gary, would you like to go next?
Yes, Gary would like to go next. I have actually two questions. Am I allowed? Okay. The first question is, could you give us a little bit of insight into who your community resources are to be able to secure feedback in terms of what their priorities are and what are the preferred means of communication beyond the healthcare providers? And the second question, because it may be related, is have there been any requirements for modifying your objectives or your processes to comply with current NIH priorities, and restrictions?
Mm. In terms of the first one, I think one of the ways we're getting feedback is really through our existing relationships and building on those to get more people, kind of like it as a snowballing effect. So I'll say like in the Colville, Northeast Washington site that we did a listening session in, we have a very active practice champion. We actually have a faculty member from the area as well. And you then help us with connecting with community organizations that then helped us find community members. And like we had a group of people who were like community organizers to local practitioners to chaplains to like, and I didn't know any of the people, right? Like going in, but like people who we knew other people. So I think it's really that snowballing effect to get to community members, but also try to make sure we have a broad arrangement of different people. I think in terms of your second question, I would say that fortunately they chose this initial pilot to focus on rural areas. And I think that remains a bipartisan issue to focus on rural health and the needs of rural individuals. I would say how we frame certain things has definitely changed to make sure that we're framing things in kind of light of new language.
Thank you.
Yeah.
That's what I sort of suspected.
And the only thing I'd add to kind of the first part of in Utah, our community health centers have a primary care association that represents all of the FQHCs around the state. It's a very strong, very involved group that has patient advisory panels and also meets with the CEOs of the FQHC. So we really work through them, who have a lot of trust with the individual health centers. I don't think that arrangement exists in every state, but that's been a really critical asset for us in terms of the partnership.
Thank you.
And the
see.
second question, requirements to modify your objectives or processes to comply with NIH?
Yeah, I mean, I think Sebastian really said it correctly. Like, nothing has changed about the fundamentals of the project. Sometimes the way we describe it has evolved based on those changes. But fortunately, we've been able to continue to do the work that we set out to do.
Thanks. I
So
had
it's
a headphone
vocabulary based.
problem. Say again, Gary?
I was just saying, so it's vocabulary based.
Right. My apologies. I lost my headset capability for a moment there. I want to switch over to a question in the chat. Jen Lavoie says, do you have a main hub for communication for the network? Is it for anyone or all who is involved? And if so, how is it moderated and managed?
We don't have a like I think you're thinking like a chat room or some sort of forum where people can discuss. We don't have that. That's a good idea to explore, I think. I think our experience with those in the past is they take a lot of work to set up and sometimes aren't very widely used, but that's something we could definitely explore in the process. In terms of how patients are getting involved in efforts, um, we have several patients on our advisory board that we set up that meets quarterly. Care for Health has now two working groups that each hub is sending representatives so that we have patient representatives on. And I think the listening sessions, some of them are clinicians, but some of them are with patients and community members as well who represent those patients. So we're definitely getting involved in ways that are beyond just being study participants.
Anything to add, Julie?
No, we similarly don't have anything formal set up like Sebastian was talking about, but I think there are some opportunities to think more creatively about how to do that.
Thank you. Megan, would you like to unmute and ask your question?
Sure. Hi, Julie and Sebastian. Thank you so much for this presentation. It's really interesting. And my question is to both of you. So yeah, looking through your BeatPain study, I've been thinking a lot about how to incorporate decentralized clinical trials into a practice-based research network. And there's some obvious win-wins, and then some areas where I'm like, okay, how would we balance this? And so one of them is a pillar of PBR research. So Sebastian, it's like thinking through not to disrupt clinical practice or adding more burden on the clinical practice. And so Julie, you mentioned like different referral out pathways through the EHR, which we've done successfully. And I love that integration outside of the clinical office with the research team. But then I'm wondering, like, the telehealth piece, and even if all of the participant tracking and everything is done outside of the clinical practice setting with the research team, they're likely, depending on the study, would be follow-up clinically delivering the intervention, or like if there's a pharmacological or behavioral intervention or telehealth. So that would fall back on the clinician, I would assume. So I'm just wondering if you could speak on that tug and pull, or how you've been able to navigate that with the practices.
Yeah, I can start on that. I mean, I think this is really critical, that the workflow to be as minimally disruptive as possible is crucial. And so we've been very attentive to that. And in our study, where we had the time for some planning, we really did some socio-technical kind of assessments of like, how do people make referrals and how can we just embed within that and try to just be one more place where you can refer someone. And then I think your other piece of this is also very spot on in terms of doing the research outside of the clinical setting, which is the way we've designed this project. So we now this is a challenge for sustainment, but we centralize the physical therapists and train them, and they sort of virtually reside here at the University of Utah. So we manage that whole process and follow-up assessments. We communicate back to the providers as you would in this kind of a clinical situation, so they know what treatment the person's getting, generally how they're doing, if there's any problems. But we handle all the research-related activities, getting follow-ups, et cetera.
Thank you. Yeah, that makes sense. We have experience with that with an epilepsy study, so that the actual treatment delivery is outside of the primary care clinic, and the referral is just in the primary care. Do you have examples or experience from other projects where that feedback came back to the clinician of the next steps of treatment? You know what I mean? I'm just wondering if you have experience navigating that piece within the
Yeah, I mean, a
program.
few things that come to mind are situations where there's a significant change that's noticed by the telehealth physical therapist in the person's well-being. So we've had a few individuals who've experienced a mental health crisis, and because we're in contact with these folks, we may be the first. And we've had instances where there's such a good relationship with our provider that the patient reaches out to that person. We had a person who experienced homelessness sort of suddenly. And so, often it's kind of in that domain where then we need to really make sure to communicate that back to the referring provider so that they can engage the support services that are available to try to assist that individual. So, given some of the complexity of the patient populations that receive care in these settings, things happen. And, often what we find is we're the person who's really in contact with that patient who identifies something. And it's often in these kinds of behavioral mental health domains.
It sounds like it's quite a balance between research and the responsibility of good clinical practice that eventually, as you move forward, is something that then does have to get integrated into the practice, or that learning is lost. So there sounds like there's the follow-up piece to consider there. Gary, I see your hand up. Do you still have another question, or are you just thinking as we go along?
No, I just was a little bit forgetful. So now, having heard that cue, I'm lowering my hand.
Okay, thanks. I have one more question if we have time, Sheila. Yep. Okay, great. So Sebastian had mentioned at the beginning of that one of the goals of the CARES project, and the phrase was co-designing existing studies. And I have been on projects where the goal was to listen and to reflect in the study of in the design of a study, for example, what it is that, let's say, matters most to patients, to put a quick phrase to it. And I want to acknowledge here Jen Lavoie, who was part of a team that helped me learn to value that and to practice trying to do it. But when we say co-designing existing studies, we recognize that research is not, a hobby. It's a genuinely complex endeavor that builds on years of past learning and methods that are still tested and tried and argued about, and develops something that will be feasible and novel and relevant and important, not only to the community, but also to the funder. So what are your thoughts about, at this point, in the CARES project, what does co-designing existing studies mean to you?
I think it's a process that we're learning. As you kind of mentioned, it takes years for someone to kind of like like it took years for each of us to like to become researchers, right? Like and to develop that training. So it's the same, I think, for everyone who's involved in how we engage kind of our patient community in co-designing studies. I think at this point, some of it is initially getting their clinician or patients and their questions. So I think one of the questions we asked at the beginning in a focus group was think back to your past 2 weeks in clinic and like what questions could research help you answer from your clinical practice, right? Or if for patients, like what things have you gone to your doctor about and been frustrated because there was no clear answer? And getting that initially. And then I think at this stage, unfortunately, like we're doing some of the development between that and the concept, and then bringing the concept back to patient our advisory group and to patients who initially suggested things and saying like, does this resemble, right? Like, but having them actually walk through each of those steps, I think that's definitely something we strive for. But we're not quite there yet, I think. And you're right, like it takes a lot of time. And for people who are full time working or caregiving or whatever they're doing, like they don't have that time. So I think we're also trying to be respectful of people's time and not just engage people who do have time, but that often represents like a demographic that has a certain privilege, right? So like we want to make sure we're representing the perspectives of all.
Have you seen differences in how different communities respond to the invitation of picking up what can be a intimidating process? You know, you're meeting with people with PhDs and MDs, and you're supposed to say something intelligent. And does that fit the different communities you've been working with so far, and your different sites for BeatPain?
It's a good question. I think I guess maybe this is just represents where I sit in terms of that relationship. And I think, speaking personally, I've certainly learned a great deal about how to be hopefully a better partner to non-academic settings, which I wasn't used to, in terms of maybe some of the things you're talking about, really understanding what is of value and what's not of value for partner settings, and having to realize there's a balance between, like for me as a scientist thinking about, boy, it'd be great to like have a placebo group in this study and realizing like that's just not going to likely be, or a no treatment group or something like that of like, that's not going to build trust in partners that I'm trying to build trust with if we, get them excited about research and then don't offer anything because of in service to the science. So that balance of like making sure that we're addressing a need in a tangible way, and then balancing that with maybe what me as a scientist would most want to do, including just the research question itself, is something that I've learned a good deal about. I don't know that I've experienced it the other way, but that's not my position or my perspective from the standpoint of staff clinicians. I haven't experienced that they've been timid about telling me if they think we're not doing what we need to do.
That's great, Julie. I'm so glad. Sebastian, were you going to say something?
That sounds great.
Okay, that is great. Thank you. It maybe it is just intimidating to me to think about how do I do this well. But we're looking so much forward to learning from what your experiences are and how to do this well. So thank you so much. We, as Sheila notes in the chat, we have a lot of learning to do as we establish a hub in our northern New England regional area, which is a goal of ours. I think I'm not seeing any more questions or comments. Any last minute thoughts before we close down? Then I want to, yes, Jen.
Just want to say good luck. And, luck is something about showing up and having and working really hard. So keep up the good work.
Thank you.
Yeah, absolutely. Absolutely. It's quite a pathway that you're on, and we look forward to hearing more about it. So this is great. All
Thank
right.
you.
So thanks again to Julie and Sebastian for sharing their thoughts, and for all of you for showing up and listening and thinking and asking great questions. That's how we learn.
Thank you for having us.